Okay, for hemorrhagic stroke, the management here is the same as in head trauma because this one, what were the three risk factors again for hemorrhagic stroke? Yeah, uncontrolled hypertension. What were the two vascular problems? Aneurysms and AVMs. All right. So all these three involve bleeding inside the cranium. Now, it's also possible that an acute ischemic stroke can convert to a hemorrhagic stroke. Okay, it's also possible. Although as soon as you're admitted to the hospital, that's less likely. But of course, if the patient continues outside the hospital with no intervention, then that could convert. Okay, because remember what happens to blood pressure after an acute ischemic stroke? Pressure increases, right? So if it remains uncontrolled, meaning, of course, that means the patient did not seek intervention, then that could convert. Okay, so initially it may have been acute ischemic, but then converted to hemorrhagic stroke. In the hospital, we can prevent the conversion because of tight blood pressure control. Okay, so we have frequent monitoring for the acute ischemic stroke patient. Also, this could also happen during what do we give acute ischemic stroke but patients again? TPA. So it could also happen as a complication of TPA, right? So let's say the doctor missed one or two contraindications, for instance, okay, or the patient did not know or wasn't able to give that history, and then the patient who had contraindications received the TPA, then that could convert to hemorrhagic stroke. So I gave this example last week. Patients on anticoagulants, or let's say did not know or are new to cocaine, for instance. Okay, so McKnight made a 2-inch row, okay, instead of just a few millimeters. Okay, so that's a possible cause. I already talked about AVMs, aneurysms, and of course, severe uncontrolled hypertension. Remember what we did last week when I described what are the three things again inside the cranium? Brain tissue, 80%. What else? Okay, blood and CSF. All right. So what happens again if volume in one or more components increase, just like that glass of water we talked about, what will happen? Okay, so something has to be displaced, right? Okay. So we'll, in one of these pages, it will talk about that concept. That concept is called the Monroe-Kelly doctrine. Now, I forgot to mention that the Monroe-Kelly doctrine only applies to a closed head injury, such as hemorrhagic stroke. Okay, so it will not apply. So let's say who drives motorcycles here? Okay, so let's say Miss Bailey drives a motorcycle without a helmet, right? So the helmet is important for one of two things. So it will prevent head injuries, but let's say she's traveling at over 80 miles per hour, no helmet can protect you anymore, right? But at least all of your brain tissue is inside the helmet. Okay, so it won't be on the first responder's shoe or another motorist tires. Okay, so we can bury you complete, okay, with no scraping your brain tissue off the asphalt or against the guardrails. Okay, so that's good. Now in hemorrhagic stroke, so same principle applies. So all the Monroe-Kelly doctrine is saying is, since it's already 100%, we already have 80% brain tissue, 10% blood, 10% CSF volume, that's 100, right? So we cannot fit a tumor, hematoma, swelling. There's no room for that, right? Just like that glass of water. So if there's any increase in one of the components, then volume in another component must be displaced. You agree? Okay, just like that glass of water, something has to go. There's only room for 100% here, right? So always consider that. But again, that only applies if the head injury is closed, meaning there's no skull fracture, and also in the case of hemorrhagic stroke. That also applies here. Say again. Monroe, that principle, Monroe, okay, it'll be written somewhere. Okay. So the difference between hemorrhagic and acute stroke, there are a few, although the effects again will be similar, depending again on which part of the brain had the hemorrhagic stroke. The onset of symptoms here will it be acute or gradual in hemorrhagic stroke? It'll be acute because all of a sudden, because will these patients have a TIA? No TIA here because the rupture of the blood vessel is sudden. Okay, so therefore the onset of the symptoms is acute. Prevention again, the only one here we can prevent is of course the hypertension. Okay, so of course atherosclerosis also contributes to hypertension. So yes, that's one way to prevent it as well. But as far as AVMs and aneurysms, the only manifestations you'll have if you have those are headaches. So if you have frequent headaches, it won't hurt for you to get scanned. All right, if your symptoms are frequent and they're persisting despite over-the-counter relief medications, for instance, they don't work, then tell your provider. A one-time CAT scan or MRI will easily find these vascular anomalies. Let's look at a few complications after hemorrhagic stroke. There are up to 6 complications here. Now, after the stroke, the hemorrhagic stroke, because this involves bleeding inside the cranium, correct? So, according again to the Monroe-Kelly doctrine, what happens to if there is increase in volume? In this case, if a blood vessel ruptures, what will increase? Is it brain blood volume or CSF volume? Blood volume will increase, right? Because now there's blood that is not inside the blood vessel, correct? It's now leaking outside and therefore will displace the other tissues. And we already agreed last week what will be displaced first because it's the nearest the opening, the brainstem. Okay, the brainstem will be displaced. And what are the functions again of the brainstem? Okay, all our vital functions. Okay, so consciousness is there, breathing, heart rate, and blood pressure control are all in the brainstem. Okay. So what we're trying to get to this section is when we say complications, they will result whether you like it or not, meaning the patient's hemorrhagic stroke is only the primary problem. There will be up to 6 secondary problems which will arise. It's not like, oh, if they happen. No, these six secondary injuries will occur because of the consequences when you increase one or more components inside the skull. Meaning you can't help it, therefore, that's what I'm trying to say. Correct. Well, because of the volume of one of the more components rather. Again, there are only 3 components in there. There's brain tissue, there is blood, and there's CSF. Now, yes, blood volume will increase because in the form of a hematoma, right? But once there is a hematoma and displacement of the brain structures, think of also of the ventricles of the brain. Once those ventricles are displaced, what happens to CSF drainage? It also slows down. So therefore, what will happen to CSF volume as well? It will also increase. Okay. And the stroke itself, which will kill one or more parts of your brain, will also cause tissue swelling. So all in all, there will be increase in the volume of all 3 components. Okay. So therefore, is this an emergency? Yes. But think again of the 6 complications here because they are going to be in essence the secondary injuries, meaning after a hemorrhagic stroke, the patient's problems are only beginning. Okay, that is just your first problem. There will be 6 other problems that will follow in the next 24 to 48 hours, right? So that's why you see, so the concept applies to head injury because have you ever seen or know somebody who had a head injury, a mild TBI, a concussion, or let's say sports, okay? So let's say we don't have examples in our family, but look at sports, professional sports. What happens when they enter into a concussion protocol? Are they allowed to play? Why not? And what happens over the next 24 to 48 hours? Why are they put in close observation? We're watching actually for one or more of these six secondary injuries, okay? Because they will follow the primary injury. Okay. So first one is cerebral hypoxia and decreased blood flow. This is caused again by increased ICP, okay? Increased intracranial pressure because again of increase of either the blood volume, the CSF volume, or the brain tissue volume. So this will have, plus again, once the brainstem is pushed out or herniated, what will happen to the respiratory rate? And what happens to oxygen levels? And what happens to CO2 levels? Okay, and it will snowball from there, right? So we looked at it last week. There were interventions, right, in the management of increased ICP. Okay, so what happens again if there is increased CO2 level? What will happen to blood vessels in the brain? Vasodilation. So high CO2 or hypercapnia or hypercarbia is a potent cerebral vasodilator. So once blood vessels dilate, what happens to blood volume? Increase again, further contributing to increased ICP. Okay, so that's cerebral hypoxia. And decreased blood flow, of course, whenever there is increased ICP, is it any different from compartment syndrome? In fact, the skull is the most rigid compartment in the body. We have compartments in the arms. Arms, legs are compartments, right? The torso is a compartment. This is the most rigid compartment because this does not expand. Your trunk will expand. Arms and legs can expand, but can the skull expand in a grown-ass person? No, it will not expand. So therefore, the disaster is worse if the compartment syndrome happens inside the brain. So that will decrease blood flow. So again, the same effect as compartment syndrome. One of the complications is a seizure. Seizure will be triggered because of the increased ICP. I'd say when the what's the normal ICP again? 10 to 15, right? Millimeters of mercury, or 0 to 15 millimeters of mercury. So once this reaches around 22 or higher, 25, people usually have a seizure. So expect, therefore, your patient's orders to include not only seizure precautions, but anti-seizure medications. Okay, it'll be given either Q6 or Q12 hours. Okay. Another is vasospasm. So this will narrow the blood vessel. So of course, this is an effort, again, responding to bleeding, right? So when there's bleeding, what is always the response of the blood vessels? To constriction, and that can lead to vasospasm. So here, vasospasm can frequently occur 7 to 8 days. We're still under hemorrhagic stroke. And here's increased ICP. And we already had the management, which includes mannitol. Okay. My first hospital job was in a small government hospital. And we had everybody there. We had one medical ward. We had about 40 patients in that ward. Everybody was jumbled in there. So medical, surgical, and neuro patients, there's only one. So everybody was in there. So when we give mannitol, of course, we didn't have IV pumps, so we had to push mannitol. And we didn't really were supplied with gloves. We had to bring our own gloves. So sometimes we went without gloves. So we'll have we'll spill mannitol on our fingers, and you can say that we didn't really have time to wash our hands because when we see each other outside at a grocery store, for instance, I'll see a coworker with crystal powder on their cuticles. I said, "Oh, you were pushing mannitol today, huh?" He said, "Yeah, I was." Okay. It was basically embarrassing. Okay, but we had to work with what we were getting. Okay. We got paid, of course. At least the pay wasn't late. Okay. Got paid on time. But very poorly funded. Unlike here, you have good budgets in your city hospitals here. That doesn't exist in the third world. An option for mannitol, because mannitol is a diuretic, correct? An osmotic diuretic. What is always the effect of any diuretic on blood pressure? Whether it's osmotic, loop, thiazide, it will drop blood pressure. Okay. So in the event that you have a hemorrhagic stroke, which of course is going to increase ICP, correct? Now, the automatic response of the body is supposed to be increasing blood pressure, right? After a stroke. However, when you have blood loss because of the stroke, what will happen to blood pressure? It will actually drop. So what is the effect now? Can you give mannitol if the blood pressure is low? All right, so therefore that will be a contraindication for mannitol. An option which has the same osmotic effect will be hypertonic saline right here. Correct. It will have the same effect. It will pull water out of the interstitial spaces, out from the cells, causing decreased swelling in the brain. Plus, it will increase intravascular volume and also blood pressure. Okay, so this is an option. But careful again, because if the patient has comorbidities, let's say heart failure, chronic kidney disease. So there are, of course, contraindications for everything, but this is an option. So again, if the patient has problems receiving mannitol, the other option is hypertonic saline. I've never really given 7.5 or 23, but 3% saline is an option. Yes.
Any shunting of blood to those areas issue here in this situation? With the,
Shunting, you mean from because of sympathetic
right.
stimulation? Yeah, same. There will be sympathetic stimulation here. Well, with mannitol, again, we don't worry because this will cause it will do its job. It will cause reduce cerebral swelling, cerebral edema. That's the whole purpose of giving mannitol, because you have increased ICP. To decrease that, you give mannitol or hypertonic saline. So hypertension, this is again the underlying condition why we're in this mess in the first place. So the uncontrolled hypertension caused the rupture of the blood vessels. But again, what's the guideline again for blood pressure in hemorrhagic or ischemic stroke patient? Okay, so we want the pressure to be slightly higher, right? We don't want a normal blood pressure. And these are again your options. I believe your William Edwards patient, which is due by midnight, just a reminder for everybody. I already opened it. It's on DocuCare. So it's like a VSIM documentation. Okay. There are two who were not enrolled. Better enroll because you won't get the assignment.
Okay.
And Juanita too.
Me? It's supposed to show information. It's like
It's supposed to. No, I already opened it.
it's supposed to look like this.
I'll double check. Okay, take care again when you have these orders to control blood pressure that you don't overdo it. All right? Because again, we want the blood pressure to be at least 150, but not over, okay, 220. Other interventions, of course, are stool softeners. Okay, because there will be constipation here because these patients are bedbound. So management for hemorrhagic stroke is, of course, there's bleeding. So how do you manage bleeding? Okay, so we need surgery here. So patient will have to undergo craniotomy, and craniotomy is not in this chapter. It'll be under head injury. So you have to open and then drain the hematoma. So here's the surgical management. So if all else fails, meaning you already intubated the patient, increase oxygen, drop CO2, manage fever. What's the position again of head of the bed? 30 degrees. Okay, so you already did that. You gave mannitol. Nothing's working. ICP remains high, and your CPP is dangerously below 70. Okay, it's in the low 60s, for instance. Then we'll have to do surgery. All right, let's go now to head injury. Any question? As far as the home care for stroke or hemorrhagic stroke, it's the same as in ischemic stroke. But of course, different risk factors, so different future prevention. The rest are under head injury.